I think you love it.
Yeah, I'm here for that.
Yeah, so do you all see my can you all see my slides?
Yes, yes.
Okay, that's good. Joseph, you see the slides?
Yes. Yeah, they are here.
Okay. Okay, so I believe, Joseph, you've already hit the record button for those who won't be able to join, so we can
Yeah,
upload it on YouTube. Yeah.
sure.
Okay, so welcome everyone. It's another Sunday, and as usual, Sundays are for AfroDX cases. So time Joseph discusses a case for fun today. So um, I have to admit a number of people here. We have many attendants today. So Joseph, whenever you are ready, let me know so I can start.
Yeah, I'm more than ready.
Okay, so here is the chief concern. So for those of because we have a number of new people, just a few ground rules. So I'll be presenting this case to Joseph. Joseph doesn't know anything about the case. So the purpose of this presentation is to learn from Joseph how he approaches different clinical problems. So the purpose is not exactly to get the diagnosis right. We are more interested in the journey for Joseph to share with us how he thinks through a case. But of course, it's impressive that Joseph is a seasoned clinician, so he gets the diagnosis because he's good at what he's doing. But then that is not the purpose. Our target is to see how he reasons through this case. So whatever the outcome, I believe you learn a lot from his approach. So, Joseph, this is the chief complaint. We have a 69-year-old female who presented fainting episodes for 6 months. We can start from there.
Okay, first of all, thank you for taking your time and preparing the case. I believe you took care of the patient, and you saw it is valuable if you present it here so that we can learn. And also, thanks for the turnout. I think people are interested with this new kind of learning of medicine, the case-based learning. So, this is an elderly female with fainting episodes for the past 6 months. So, fainting is a bit vague. If you are told fainting is a bit vague, you are used to hear words like loss of consciousness, convulsions, or syncope, which can all be interpreted as fainting by someone who is reporting that. And you cannot tell people what to report, they report what they see. So, for me to have a framework of what is this patient presenting with, I should broaden my mind and take in all the things that I think can be interpreted as fainting by the patient or someone who is taking care of this patient. So, someone saying fainting episodes, so these are multiple episodes in the past 6 months, they can be loss of consciousness, or they can be syncope episodes. And as we hear from the HPI, it can come clear: is it syncope episodes or is it loss of consciousness? Some clues will include, for example, they are telling us they'll faint and woke up immediately, which I will interpret that as syncope episodes. But then, if the story will be like they lose consciousness and they lie down for 30 minutes, whether they have conversions or not, and they wake up, they are drowsy, confused, or what happened, that would be interpreted as a seizures. Why is it important? The two are very different approaches. So I won't go into trying to go down the line of one framework here because it will be a waste of time without knowing exactly this. But again, some things can mimic syncope or loss of consciousness that should be taken into account. Of particular importance is hypoglycemic episodes. People with hypoglycemic episodes, they can be having fainting episodes. If it is just one episode, you can say, okay, even some strategic strokes can resemble fainting, but multiple fainting episodes, 6 months, they can't be strokes. So, hope to hear more from the HPI and see where I can put these fainting, whether it's syncope episodes or pure loss of consciousness or even seizures. Yeah, to you, David.
Okay, thank you, Joseph. So we'll proceed with the HPI, and this HPI will have, I'll present it in a number of aliquots. So here's the first one. This patient had a total of 5 episodes in those months, and all of them occurred when she was rising from bed. Um, so the duration between these episodes was about 1 to 2 months, and they were preceded by lightheadedness and blood vision, and it was followed by falling and brief loss of consciousness, and then she had spontaneous recovery in less than a minute. No chest pain, no palpitations, sweating, convulsions, or confusion. No identified triggers like cough, sneezing, defecation, etc. So we can discuss that one.
Yeah, so as I said, now it is getting a bit clear. 5 previous episodes that occurs when she's rising from bed. So these are more likely to be syncope episodes more than anything. And I'll tell you why. So all of them are happening when this patient is upright, meaning rising from bed. And then, as syncope is defined as transient loss of consciousness caused by global hyperperfusion of the cerebral hemispheres, as you can see here, the recovery is in less than a minute, which tells us this is a syncope. It's more likely to be a syncope episodes. Not 100%, but it's more likely to be a syncope episodes. So, without going further, so what are other things that can mimic a syncope and they can fool you? So, the first one, as I said, is hypoglycemia, and we will be told later whether that is the case. But another is a seizure, and if you are reading a seizure or a syncope, you might think it's very easy to differentiate between the two. But if you're sitting in a clinic, someone is in front of you, like they had the episode yesterday and they're telling it today, you realize it's a bit difficult because many things can be in a seizure but can also be in a syncope. For example, the absence of conversions that we are told here, you might think, okay, the absence of conversion, if there is conversion, it means it's a seizure. How about the absence of conversion? Yeah, there are non-convulsive seizures that can occur, and someone doesn't converse, but they are having a conversion. There are no identified triggers. Still, it goes in the same direction that It's less likely to be a seizure. Other things, yeah, spontaneous recovery in less than a minute. Okay, so I'll go into the line that I will be solving this case as syncope episodes, multiple syncope episodes in the past 5 months, in the past 6 months, more than anything else. If there is anything else, will be told later. So let me share my approach or my framework when I approach someone who has a syncope episode. If you read the literature on syncope, you'll find some words like reflex syncope, orthostasis, etc. For me, I find that to be less useful clinically because it's so difficult to remember. Mine is, I think, what happens for someone to have a syncope. So people who have a syncope, usually they are upright. So they're standing or sitting, and then they fall down. Less than a minute, they are up. That translates as their brains lacked blood supply for a short time period. And since the brain is very selfish, it makes someone to lie down so that it can get its blood supply and then continue its other things. So why should the brain misses a blood supply for a second? It's because there was a sudden drop of blood pressure. So to me, when I approach a case of syncope, I will still a bit of the approach of hypotension to describe to approach syncope. It's so easier. Why? Because if you write the formula of blood pressure, you realize you take cardiac output times total peripheral resistance, and cardiac output will be stroke volume times heart rate. So you'll be having blood pressure, cardiac stroke volume, pulse rate, and then total peripheral resistance. So if we have a sudden drop of blood pressure, any of these three is affected. So if we start with a stroke volume, things which can cause a low stroke volume include hypovolemia of any sort, whether it's bleeding or non-bleeding, like vomiting or diarrhea, profuse sweating without drinking water. But you can have obstructive causes that can cause a low stroke volume, and these include things like pulmonary embolism. We solved a case here of pulmonary embolism presenting as a syncope. Another thing can be even pulmonary hypertension, pericardial effusion with tamponade physiology, aortic stenosis, hypertrophic obstructive cardiomyopathy. All these they can obstruct and cause a low stroke volume. Another entity that on that formula is the heart rate. So anything affecting the heart rate can cause syncope, and it can be fast, so tachyarrhythmias, or slow, bradyarrhythmias. In bradyarrhythmias, I've seen multiple patients with an advanced degree of wavy block, second or third, presenting with a syncope. And in tachyarrhythmias, we're talking about supraventricular tachycardias or the ventricular tachycardias themselves. On the total peripheral resistance, we're talking about the tonicity of the peripheral blood vessels. So the tone of peripheral blood vessels are driven by the sympathetic tone, while the parasympathetic tone opposes that. So what can cause a reduced sympathetic tone include medications such as blood pressure medications, beta blockers, CCBs, and others. And what can cause, other diseases that can cause a decrease in some sympathetic drive include diabetic neuropathy, Parkinson, and I believe there is another. Okay, I'll remember it later. On the other hand, some things can also drive up the parasympathetic tone. And so there are people who are having a hypersensitive, uh, uh, a hypersensitive carotid sinus. If they're doing is a maneuver which involve manipulation of the carotid sinus, they pass out. So someone is telling you when they are reversing their car and they're turning on the on either end to look back, they pass out. Or when they are shaving and passing the shaver on the either side of their chin, they pass out. Or when they have a tight necktie, they pass out. So that would be a framework that will be approaching this case into, and I hope to hear more from David.
Okay, so we move on. So that was the first one. So as I told you, I'll present it in early quotes. So she also presented with another complaint. Um, so about 6 months ago, so the same time period, she noted increased the frequency of urination, and this was more during the night. And it was progressive from about 2 episodes in the beginning, but it went on to 5 episodes in the last month. And she could wet herself if she delays to go to the washroom. She reports feeling of incomplete bladder emptying, but no history of painful urination, no blood in urine. No flank Bohanga. That
Okay. Are you done, David?
Yes, that is the second one. So
Okay.
you can discuss that one.
Yeah.
Yeah.
So, yeah, the case is evolving very nicely. Now, we started out with what we think is syncope, and then we are given another problem. And I can summarize this as urinary frequency. And if you look at this, it is saying more during the night. So, is it generally urinary frequency or just nocturia, increased urinary frequency during the night? We solved a case like this last week, and it won't be a bit difficult now because so if someone has increased urinary frequency, what we are thinking is it because their volume has gone up, or is it because some by from other pathologies like uh, uh, an irritated bladder, which is less likely for 6 months, or other causes that can cause a bladder to make someone to urinate frequently. So I'm trying to think of other things here. If this was a male, a BPH would be high up, but this is a female, I believe, David, right?
Yes, this is a female.
Yeah. So other things that I can think there for 6 months include maybe a hypersensitive bladder. That is one. But again, females have elderly females have pelvic floor pathologies later in life with risk factors like multiple pregnancies previously and such, which can cause also which can cause also urinary frequency. On the other hand, we will be told later whether it's a volume problem, and if it's a volume problem, we have to categorize it. And the volume problem will be she's producing more than normal urinary volume per day. And what we are targeting here is whether she's having polyuria. And polyuria is when you have more than 3 liters of urine in 24 hours. And if that's the case, we will categorize it into the solid diuresis or water diuresis, as we did in the last case. And that will be obvious. So, still urinary frequency and then syncope episodes. Are they related? Yes, they can be related. As we said initially, so one of the things is someone is volume down and they're having syncope. So what if this woman is losing a lot of urine due to increased frequency? That's why now she's having multiple syncopal episode
Hey.
when she wakes up in the morning, because in the night she urinates a lot. In the morning she's dehydrated. If you're dehydrated, it's more likely to have a syncope. So I can connect it on that area, and still realize the bigger problem here is syncope more than this urinary frequency. More info, David. David, you are muted.
Oh, sorry. I was saying, can you summarize, because we have people who joined after we started. So can you summarize where we are so far?
Yeah, so we are discussing a case of an elderly woman in her late 60s who is presenting with syncope episodes and increased urinary frequency for the past 6 months. She has had 5 syncopal episodes up to now, between 1 to 2 months, and they usually happen mostly in the morning when she wakes up. There are no red flags to her syncope like chest pain, awareness of heartbeat, difficulty breathing, etc. Yes, I think we are there.
Okay. Thank you, Joseph. So we proceed. Yeah, so that's the last complaint. So this patient had 3 complaints, and I thought a better way would be to present it in terms of aliquots. So this is the last one. 5 months ago, the patient noted right upper limb shaking. And this involves the wrist and fingers. It is noted when she holds a book, a cup or spoon, and it has been progressively worsening. She is limited in her. It's associated with occasional forgetfulness of recent events, but there is no altered mental status, no personality changes, no speech changes, no difficulty swallowing, cold or heat intolerance. She has no difficulty in initiating movement. She reports occasional painful spasms of the lower jaw. So that's it for the HPI.
Okay. This is a nice case, David. Thank you. Yeah, so now, first problem, syncopal episodes. Second problem, urinary frequency. And then now we are having a movement abnormality. This is the third problem. Movement abnormality, it's easy to tell when you see it, but you cannot see all of them. That's why we are here, and we're told she's having a movement abnormality, which is in the same period, the same time period with all these other symptoms. And David is telling me here a unilateral shaking of the upper limb, which involved the wrist and fingers. And it is so significant such that she cannot perform activities required to be performed by that upper limb. And something is alerting us here. This thing is progressive. So, what are the possibilities? And should I translate this as what should I call this? Should I translate this movement abnormality as okay? Let me start over now so that I cannot be lost in this. So, unilateral upper limb movement disorder, which involves shaking. So it's easier to say this is a tremor, a unilateral tremor, more than anything else, because yes, as I'm saying, if you see it, you can tell. But for the information that I can gather here, it's easier to say this is more likely to be a tremor. So what are the possibilities? A unilateral tremor. We are not told if it happens also at rest, but that's not a problem if we'll be examining this patient to know later. And we can move with both of them equally. So let's assume maybe it is on the other end, maybe it is at rest on the second end, when it is maybe it is during activity. So if we hear someone with a unilateral tremor that is progressive, we all want to think of Parkinson. But I wouldn't be quick to do that, because a lot of other things are not making sense. One very important thing here that came with this symptom is it's associated with occasional forgetfulness of recent events. So Parkinson's is just a movement disorder. The memory issues will come very late into the disease. One mimic of Parkinson that start with a movement disorder with CNS symptoms is, if I can recall correctly, what we called dementia with Lewy body. We'll see later, but that's the thing that I can recollect, that as a tremor, at the same time forgetfulness, dementia with Lewy body. But if I say that, I'll be limiting myself, because I have assumed the diagnosis of this patient to be a chronic neurological disease, which might not be. So if I can approach it on the other way, so that I won't miss other possibilities here. Increase the forgetfulness is a CNS thing, should be localized into the brain. And one hand which is having a tremor, that can be anywhere. It can be from the brain, but again, it can be in the hand itself. So maybe we move on, but I'm not so confident with this third complaint and third aliquot, in such a way that I'll have more to say when I see on exam what is this movement disorder, and then what is this forgetfulness? Is it there when you do maybe the MOCA or mini mental exam when you're doing the CNS? So if we combine the three now, syncopal episodes, urinary frequency, and then some things which look like a CNS, which look like a dementia with Lewy body. It's hard to integrate for me, the three. The two, yes, but this one, third one, I think I'll wait a bit, and I need more info. David, you're muted again.
Okay, we proceed. Okay. Can you hear me now?
Yes, I can hear you.
Okay, so review of systems are nothing significant. On the skin, she had no rash, no hardening, no color change, no hair loss or nail changes. On musculoskeletal system, there is no joint pain or swelling, no muscle pain. Past medical history was non-contributory. She doesn't have any chronic illnesses prior to onset of these symptoms. She's not on any medications. On family social history, she's divorced. She's a retired nurse living with grandchildren. She's a lifetime non-smoker. She does not drink, and there is no family history of similar illnesses. Yeah, so That's it about the other components of history. If you have anything to discuss, you can discuss there, or I can move on to physical exam.
I think we can move on.
Okay, so on physical exam, on general exam, the patient was fully conscious, febrile, not pale, not jaundiced. There was no lower limb edema, and she has an expressionless face. On vitals, the respiratory rate was 17 cycles per minute. She was saturating 99 on room air. The temperature was 36.8. So the blood pressures were taken in the supine and direct positions. Supine blood pressure was 136, systolic and 76 diastolic, with the pulse rate of 70. And the erect blood pressures were 110 by 59, with the pulse rate of 74. So that's the general exam and vitals. If you can discuss those, or we move on to neuro exam.
Yeah, so these vitals are very remarkable, and one should discuss them first. Yeah, kudos to whoever did this exam because he saw the importance of doing a supine and direct blood pressure. As you can see, you are all told out diagnose and orthostasis, and that's what we are seeing here. The difference between the supine systolic blood pressure and erect is at 26, and when it's above 20, you say that's orthostasis. The same applied to the diastolic. I think the difference will be 16, 17. So if it's above 10, you say it's orthostasis. Of particular importance is the pulse rate. I won't leave without also discussing with this pulse rate. So I remember there is a formula which can tell, because there are many causes of orthostasis, but you can divide them into two ways. Whether someone is having a syncope because they are volume down, or because their sympathetic drive is also sick, and you can do that with a pulse rate. So I believe it has to be like this. If you take the difference between pulse rate and divide the difference between the systolic blood pressure, it should be above 0.5 to say that their sympathetic drive is functioning normally. So if, without even going further, if I take this, it's like 4 and divide by this, it won't 4 over 20 something. It's like it should have been like more than 10. So the sympathetic drive of this patient is also sick. So it's like the easiest way is a patient with, if you ever, because the patient with diabetes are so many, they come to your clinic, and most of them, they are having autonomic dysfunction. If you see them, try this. It's very nice. I've done it, I believe. It shows the results there, and you incorporate mathematics in medicine. So this patient is orthostasis, and orthostasis can explain the syncopal episodes that this patient is having for the previous 6 months, and it is driven by autonomic dysfunction. So let's go to the exam, the systemic exam. David, you are muted.
Okay, thank you, Joseph. I believe that's a pearl added for most of us. The how to determine if this orthostatic hypotension is from volume depletion or autonomic failure. Yeah. So on a neurological exam now, this patient had no signs of meningeal irritation. Cranial nerve exam was normal. So you talked about something like well, she had a few short-term memory lapses, and on mean mental status examination, her score was 24, which is mild cognitive impairment. And then I have a video here. I believe it's playing, so
Yeah.
you can see what's happening. So when you are done looking at it, you can let me know so I can move on.
Yes, we can move on.
Okay, so that's for the right hand, which had symptoms, and this one is for the left hand. So basically, there is no movement disorder in the left hand.
Okay.
So finishing up the neuro exam, power was normal in all groups of muscles. Tone was normal except for lead pipe rigidity at the right wrist joint. And then reflexes, she had normal, but then she had an upgoing plantar reflex on the right foot. Sensory exam was normal. Coordination was normal, but this patient had bradykinesia. There was no kyphosis. Other physical exam, cardiovascular exam, BPs as presented earlier, but other findings were normal. Abdominal exam was normal, respiratory exam normal, and musculoskeletal system exam was also normal. So
Yeah.
the next will be labs. So if you can discuss that one.
Can you go to the CNS exam?
Which slide? This one?
No, the next one. Next after that. I mean, after the video. Yeah. Okay. Yeah. Thank you very much. So, also, when you gave me the general exam, there is one important thing that I forgot to mention: expressionless face. So, in all comers, expressionless face, unilateral tremor, and then you are told here that lead pipe rigidity. Everyone will say, aha, Parkinson. So Parkinson is just a word. It describes these features. These are Parkinsonian features, by the way. But is it among the Parkinsonian features? The most common is Parkinson's disease. But one thing here tell me this should not be Parkinson's disease, and that is the symptoms started with memory impairment. What we see in Parkinson's patients, and I've taken care of Parkinson's patients late in their diseases when their relatives don't want them at home, then bring them in the hospital. Those are having memory issues. But initially, there shouldn't be memory issues. So a mimic of Parkinson's disease, which has memory issues initially, is dementia with Lewy body. Another mimic of Parkinson's, which is common, I believe is called frontotemporal dementia. But I don't see here the flavor of frontotemporal dementia. So I will stick with dementia with Lewy body. And so dementia with Lewy body. And one thing that I should discuss here, because if I leave it, it won't make a lot of sense. The reflex. So we are told there is an upgrowing plant on the reflex on the right. So what does this tell us? This is telling us this is an upper neuron sign. It's an upper neuron sign. So we haven't heard of weakness or whatever, but on the same right side, we are told there is an upgoing plantar, a positive Babinski. So how does this integrate into all this? So as I said, this is an upper motor neuron sign, and you know, if we trace the motor system, it starts in the primary motor cortex, the precentral gyrus of the frontal lobe, goes down into the posterior limb of the internal capsule, goes down into the brainstem, reaches at the lower medulla, decussate on the other side, passes into the spinal cord, and then it will synapse with the lower motor neurons. So anywhere in the from the primary motor cortex to the spinal cord, there can be a lesion that causes this. But if we use our common sense, where should this lesion be? It can't be in the spinal cord because we would have seen other things. It can't be in the brainstem. We would have seen the cranial nerve stuff happening. So it is in the brain. So is this disease in the brain causing an upgoing plantar on the right side, causing Parkinsonian feature Parkinsonian feature of this patient? And many things are there. 6 months, my top will be a neurodegenerative disease because it will be a chronic disease, a neurodegenerative disease. And I've mentioned dementia with Lewy body multiple times here. But the other things are possible. Other things are very, very possible. Because to cause Parkinsonian feature, you just have to cause havoc in the basal ganglia, I believe, as you all know about the mechanism of Parkinson. So you have to cause havoc in the basal ganglia of the left side, and you have Parkinsonian features. You have an upgoing plantar. So maybe apart from what I'm saying, that's the neurodegenerative disease more likely to be a dementia with Lewy body. I would need to image this person at the end to have an MRI and look what is happening on the left basal ganglia. Is there a mass sitting there? A slowly growing mass for 6 months. What is the HIV status of this patient? I would need to know later. And if there is nothing, then so okay, maybe this is a neurodegenerative disease in which we don't see anything, more likely to be dementia of the Lewy body. Next.
Okay, we proceed. So on lab, yeah, I decided to summarize them because this patient was extensively investigated. So I just thought I could put a summary of things, not to take you through trouble of looking at values, which most of them were normal. So sodium chloride as well, thyroid function, test blood glucose was about 5.6 thing, which was within normal range. Serum B12 levels were normal. And then all serologies, HIV, hepatitis B, C, syphilis were negative. She did an ANA profile, which was negative. And then some imaging. Echo and DCG, because of the syncope episodes, echo and DCG were normal. Holter was also done, which was normal. KUB ultrasound, the positive finding was she had a residual urine volume of about 108 mils. So that was increased urinary, increased the residual urine volume. Yeah, so these are the last pictures. I think I have a number of images. So you can just take time and look at them. Whenever you are ready, you can, if you want to interpret one after another, or maybe look at all of them. And then I think I have 3. That's 1, 2, 3.
Okay. Yeah. So David, you didn't tell me about the meds this patient is on. Is she on any meds?
No, when I was presenting other components of history, I said she wasn't on any medications.
Good, good. I forgot that. So that's very helpful because some medications can cause Parkinsonian features. So yes, I'm very glad for the labs, especially the HIV, because HIV Parkinsonian features, there might be very abnormal stuff sitting in the brain. But here we have the MRI, and so this patient has neurological deficits on the right side. Should be concerned with the left side. We can try to read, but David at the end will give us the final read. So if I try much, I can say I believe this is a T2. This is a T2 weighted image because the CSF is white and so as the cortex. I squint my eyes looking at the left basal ganglia, but to be honest, I'm not seeing much. Maybe I will hear from the report, or I'll see other images if I can see anything.
Yeah, so here's another one.
Okay, so
That's another cut.
yeah, so okay, I'm not seeing anything. Another one. Yeah, yeah. Yes, at least here I can say now we are seeing a shrunken brain. A shrunken brain. But someone can say, okay, she's old. It's normal for these people to have a shrunken brain. You can do a mathematical calculation. There is something called I think, Evans index, but not in this cut. That should be a transverse cut, where you compare the width of the skull, and I think the width of the lateral ventricle or something like that. And I forgot even the number, but the positive finding I can see here, the shrunken brain, David. Hello?
Hello, Joseph.
Yeah.
Uh, okay, I didn't hear the last bit. So, uh, is there anything or we move because this is where you commit?
Yeah, so I said on that last on that MRI, the sagittal cut, I only see um the brain atrophy, which is appropriate for age 69. They can have brain atrophies. So I should commit. Yes. Um, I should say I was
Yeah,
moving.
so before you commit, I think I should say there was nothing.
Yeah.
Uh, yeah, so before you do that, on the imaging, so the report, basically it's the same. What you said, there's it's basically age appropriate brain atrophy, especially in some hemispheres. So some findings that I should maybe if I forget you tell me later so I can mention them. What we are looking for were actually not found in these images.
Okay.
Yeah, so this is where you commit.
Yeah. So if I take from where we started, I was going haphazardly. Now I realize I can say this is a neurological case. Yeah, it started as you never know. It started as think, okay, this is going to be a kind of a serious case, but it's not. This is a neurological case. And whenever you approach a neurological case, two questions that we ask is what is the time frame of the disease evolution, and two, where can we localize the lesion? So the time frame can be like seconds to minutes, or in which you'll be hyperacute, like a stroke, or it can be days to weeks, like meningitis. These are infections of the CNS, for example, or autoimmunity, like myasthenia gravis. Or it can be a subacute to acute, subacute to chronic. And a 6 month disease is a chronic disease. And under the category of chronic diseases, most commonly, these are neurodegenerative diseases, and toxins can cut across all the time frames. So if I drink alcohol now, I can have intoxication. If I have exposure to copper or zinc, these are heavy metals, I can have disease years later. So I'll prioritize a neurodegenerative disease in this case. And then where do you localize in this case? As we've done a great deal of that when we are discussing. And at the end, because this patient has forgetfulness that sits in the brain, has other symptoms, which shows this disease should be in the brain, where the basal ganglia. So a degenerative disease of the basal ganglia should be a Parkinsonian disease. Under that category, I've mentioned a lot. You can be quick to say it's Parkinson's disease, but one thing is telling me this is not Parkinson's disease because of the presence of the tremor with the forgetfulness initially. So my final diagnosis here will be dementia with Lewy body.
Okay, thank you, Joseph. It's been quite an incredible journey. I believe people have had the opportunity to peep into your brain and see how you are reasoning. A complex case, multiple complaints, some of which seem to be very far apart. I liked your approach. I think we've learned on how you approached syncope, and then the urinary symptoms that we talked about, and then the tremor. And I should say you are on the right track, that we are dealing with the neurodegenerative disease, which is not Parkinson's. So it's an atypical Parkinson's. Multiple system points here. Before I come back to you, Joseph, for I wanted to talk about is this concept of Venn diagrams, which I believe Joseph, you're very much aware with, and for most of us here, I believe we've used it in our or we use it many times when we are solving clinical cases, except maybe we have not just given it a name. So what do I mean by Venn diagrams? So we remember when we are doing mathematics, that we studied these things. So if I can get a thing here. So we are talking about many different complaints, and some of them seem very very far apart. But then they probably we see the points. We can try and see points where we can that they come together. So I'll try and draw very roughly here. So this is one circle, and then this is another one, and then this is another one. This is very rough because I'm drawing with my free hand. So let's say this is A, and then this is B here, and this is C here. So let's say A is that one complaint we are talking about, which is this patient had multiple episodes of syncope. urinary abnormalities. She presented with what was basically, she had nocturia, but then on ultrasound, maybe that's one thing that Joseph, you didn't discuss. On ultrasound, there urinary retention. And then the last complaint was a tremor. So we see syncope, which as Joseph very correctly said, that the syncope that we are talking about was basically autonomic failure. Because this patient had syncope, you see there was orthostatic hypotension, but then the increase in heart rate was not appropriate. So the patient had autonomic failure. So these complaints can be very far apart, but then there is a point where these three complaints intersect. So this is when our diagnosis is. So that's the concept of Venn diagrams, basically, that you have a number of complaints which do not seem to be very much related, but then you find a common point where they come together, and that's where the diagnosis is. So for this particular patient, there's autonomic failure, and basically the urinary symptoms that we see were autonomic failure, and then there are features of Parkinsonism. Now, that is not, as Joseph correctly said, it's not typical of Parkinson disease, which is the most common form of Parkinsonism, more than 75%. So this was an atypical Parkinsonism that was presented in one grand round at the department, and it was presented by Hamisi and colleagues. I think it was Beatrice and who else, I do not remember who else. But then, so as they were presenting this case initially, I was thinking, went to urinary symptoms, and then we went to a tremor. I kept thinking very hard before they came to physical examination and diagnostic formulation, what is going on? And then when it came to review of systems, it was an aha moment. I thought, okay, this is multiple system atrophy. And on Parkinson, there's a part where it was talking about a typical Parkinsonism. And so I remembered reading about that one, and that turned out to be the diagnosis. So basically, when we are talking of Parkinsonism, this is a generic term which is used to describe bradykinesia, which this patient had, with rigidity and or tremor. The patient had all these features. So this was Parkinsonism. And then, as Joseph said, Parkinsonism is a generic term. Then we have Parkinson's disease, which is the most common form, as I said, more than 75%. And then you have other forms. You have a typical Parkinsonism, which we are going to discuss. And then you also have secondary Parkinsonism, like drugs, infections, tumors, and many other things. Now, when we talk of atypical Parkinsonism, what makes you think that this is an atypical Parkinsonism? So first of all, when there is early involvement of speech and gait, this patient did not have those features. Also, lack of motor symmetry. This patient did not have that one, because Parkinson's, we talk, the tremor of Parkinson's is mainly a resting tremor, which is commonly unilateral. So that is what we mean by asymmetry. Now, this patient, there was also motor symmetry, but what was significant is the tremor of this patient was not a resting tremor. It was a postural tremor. So it happened when the patient holds a cup or anything. But at rest, the patient was completely normal. And then a more aggressive clinical cause. So you see in about 6 months, this patient is already limited in her activity. So there's a more aggressive clinical cause as compared to Parkinson's disease. The other thing is poor or no response to levodopa. Now, this is one of the features that are used in order to determine if this is or are we dealing with Parkinson's disease or an atypical Parkinsonism when things are not very clear. And what falls in the category of atypical Parkinsonism? So you have what we are talking about, that is multiple system atrophy. You have progressive supranuclear palsy, and then corticobasal syndrome. Of course, dementia with Lewy bodies is another thing, but then I think the most predominant thing is the dementia, which this patient was not very prominent in this patient. And then another one is frontotemporal dementia. Yeah, so that's it about Parkinsonism and the atypical Parkinsonism that we're talking about. So this patient has multiple system atrophy, and I'm just going to talk briefly about it. This is a neurodegenerative disease with autonomic, pyramidal, Parkinsonian, and cerebellar features. So the autonomic, like we saw in this patient, the orthostatic hypotension, and urinary abnormalities, which are very varied. So this patient had nocturia, which can stand alone, but she also had urinary retention. That was revealed by increased residual urine volume on ultrasound. And then the pyramidal features, this patient had a positive Babinski. The Parkinsonian features was the tremor. The cerebellar features were not prominent in this patient. So we talk of cerebellar features like limb ataxia, cerebellar dysarthria, and ocular abnormalities due to problems in the cerebellum. But this patient did not have those features. So the pathology, multiple system atrophy is one of the synucleinopathies, others being Parkinson's disease as well as dementia with Lewy bodies. So basically, there is a deposition of a protein aggregate called alpha-synuclein. But then this deposition is more widespread in these atypical Parkinsonisms as compared to Parkinson's disease. In Parkinson's disease, the deposition is mainly in the striatum, but in multiple system atrophy, the deposition happens in the basal ganglia, in the midbrain, in the brainstem generally, as well as in the spinal cord sometimes. And the epidemiology, of course, this is a very rare disease with an incidence of 0.6 per 100,000 person years. There is no racial or sex predilection, although some literatures report that there is a slight male predominance. But then one of the speculated reasons is when we are talking of autonomic dysfunction, erectile dysfunction is one of them. And it's one of the early features in males, and so it's easier to be diagnosed in males than in females. The mean age of onset is 54 to 58, but then it can occur at any age, as young as 30s, as old as 70s. And the age of onset is younger than in Parkinson's disease, which is another feature of atypical Parkinsonism. And then for motor subtypes, there are two. We have MSAP, that is a multiple system atrophy with predominantly Parkinsonian features. And then the other one is a predominance of cerebellar features. So this patient had a MSAP because she had autonomic dysfunction. She had those pyramidal features, and then you see she had a Parkinsonian tremor with no cerebellar features. So the prognosis of this disease, it progresses faster than Parkinson's. Most patients are wheelchair bound in 5 years, bedridden in 8, and median time from onset to death is 6 to 10 years. And there is no effective disease-modifying or neuroprotective therapy. Management is mainly symptomatic. And about the imaging that I was talking about, some important negatives that we did not see in this case. So um, for this first cut here was meant to expose the basal ganglia. So one of the features in multiple system atrophies, you can see there is what is called a putaminal ring, but that was not present in this patient. And then in this cut here, so at the level of the pons, you see hyperintensities across the pons, but also those were not present in this patient. And in this final cut, which is a tilted image, what you can see is in multiple system atrophy, you can see in cerebellar type, you can see there is a cerebellar atrophy of the cerebellum, which is not present in this patient. And then for progressive supranuclear palsy, there's another sign known as hummingbird sign, which is basically there's atrophy of the midbrain with the preserved pons, so resembling the appearance of a hummingbird, but this was not present in this patient. So that's it, Joseph. This was our case. Well discussed. So welcome for any reflections.
First of all, thank you very much. I think this is the best case we've ever had here. Well cracked. The exam is perfect. And yes, so if I reflect back, even if when I was going to guess the diagnosis, I realized a lot of things are not making sense here, but let's go. Especially as you say, the retention, and at even if I was still thinking of the Babinski, it didn't tally. Yeah, so was there a chance maybe I could have kept my cool and then realize what are the other typical Parkinson's, but I don't think anyway. If I would have seen MSA. Yes, I've never seen MSA. I've read about MSA. It was so far fetched for me. So yeah, but this is why we do this, and I believe apart from those who saw the patients, I am the second person who learned a lot from this patient, and I have a lot to go and read, especially. So what I'll go and read is all the mimickers of Parkinson's, multiple system atrophy, dementia with Lewy body, frontotemporal dementia, etc. So yeah, thank you for the case. Very, very good case.
Thank you, Joseph. I should say the approach to the case was perfect. This it's an esoteric case anyway, and what I mean by esoteria, for those who are not aware with the term, is another term they use for it is zebras, but I believe that is not very appropriate in our setting. So esoteria is those rare cases, very rare cases. So I brought it in order to learn from the approach rather than the diagnosis, because as we've seen, it's a very rare case. But then I think at least if we develop well our approach to a tremor, our approach to syncope, our approach to patients with varied symptoms like this one, at least we can come we can come close, because as you see, Joseph was very close to the diagnosis. He said this is an atypical Parkinsonism. So basically, he was just one step away from the diagnosis, an atypical Parkinsonism, and then we have a number of them. So maybe if he had all of them in his fingertips, it was just a matter of picking one. But then very well thought, and Joseph, you basically arrived at your destination. So it's not one of the typical cases which we say right down the middle, but then this was meant to learn, was meant for us to learn on how to approach complex clinical cases like this one. So thank you, Joseph, for the discussion. I think we are way overboard, but then I welcome the floor for any burning comments, any questions, anything before we close. Anyone with anything? I do not see any hands yet. If anyone has anything that they wish to share with us, you are very welcome.
Yeah, there were some questions from Adija on the comment section, but I think you have answered most of them in your teaching points.
Okay, thank you very much, Adija. Yes, I see some questions here, but then I believe as we discussed, I think the question have got some responses, but then I think we all have a lot to go and read about. Because I myself, even though I told you that when they were presenting the case, I just came by pattern recognition, but then I mean pattern recognition from a book because I've never seen a case of multiple system atrophy before this presentation. Yeah, so I think we all need to go and read in details about those things, especially the things Joseph talked about. Yeah, I do not see any hands so far, but I should say this is an exciting day because we have some new members in the audience. I shared the link to today's meeting with some junior colleagues. So we have a number of them who have just finished their training, their medical training at MUHAS. So MD5's class of 2024. And then I also shared with the class representatives for the class of 2023. So I believe they shared with their groups, and we've had a significant attendance today. So we are very happy to see you here. We'll keep sharing the link. Welcome very much, and feel free to comment, to ask questions, to share your thoughts during the final part after the discussant have done their reflections. But then if you have any questions and you are not in a place where you feel like you can communicate, you can also post your comment or question in the chat, and we'll see that. Yeah, so because I do not see any other hands, I thank everyone for joining, and thank you very much, Joseph, for discussing. We've learned a lot from you. I know neuro is your thing, and we have proven that today. So thank you very much, and thank you very much, everyone. See you next weekend, and have a good night.
Good night.